So thanks for coming. My name's Ricky. I'm a medical oncology consultant at Velindre, and today we're going to talk a little bit about immunotherapy, and in particular checkpoint inhibitors, which many of you will know has, I guess, changed the landscape of oncology management. So I'm going to talk a little bit about what immunotherapy is, a bit of an overview, what checkpoint inhibitors are, talk about why I think it's important for us to know about these treatments, talk about some of the common side effects that we see, but actually some of the less common side effects as well, because actually we're using these drugs so often that these less common side effects we're actually seeing with relative frequency. Talk about a case study, around a couple of patients we've seen. And then probably the most important bit is looking at toxicity management, looking at some tools that we've got available, and then I will throw some questions out to the audience. So I guess the first thing to say about immunotherapy is it's not a new concept. So we've been using immunotherapy for many years in different guises, and we know that the immune system fights cancer. We know it's always fought cancer, it's just not very good at doing it. And so, there's mouse models that show that you can develop cancerous cells and the immune system can deal with them without them becoming clinically apparent. So, we know the immune system works, and really all immunotherapy is moving that balance back in favour of the immune system. Now, there's been lots of different attempts at this. So some of you will know that in bladder cancer back in the 1970s, we started using BCG, which is the component of what causes TB. And with a localized bladder cancer, we get rid of the bladder cancer and then we inject BCG into the lining of the bladder. It causes an immune response and destroys any of the cells that are left over. So that's an adjuvant therapy for bladder cancer that's been used for many years. We got cytokines, so some of you will be familiar with the concept of cytokines. Cyto meaning cell, kine meaning attract or like. So these are proteins that the body produces which attracts immune cells to the tumour or to fight bacteria and viruses. And so in cancer we've used cytokines such as interleukin-2, which is one of these cytokines, and there's been some benefits. So we've used it in kidney cancer, we've used it in melanoma. Response rates around 10 or 15%, but it's got lots of really nasty side effects. So things we tend to see are things like cytokine storm, which is in essence where the body gets a bit overexcited and you end up getting respiratory compromise and ending up on intensive care. And so we've not widespreadly used those drugs across tumour sites. But it's all kind of changed with this, which is what checkpoint inhibitors are. And so the main type of drugs that we see are things like nivolumab and pembrolizumab, which are what we call PD-1 inhibitors. So this diagram looks a bit complicated, but it's actually relatively straightforward. We've got T cells, and T cells recognize tumour cells, and they recognize viruses and bacteria, and their aim is to try and kill tumour cells. But tumour cells aren't a big fan of being killed, it's not on their to-do list of life, and so they put a protein on the surface called PDL1. It stands for Programmed Death Ligand 1. It doesn't really matter what it's called, it's just a protein that sits on the surface of the tumour cell. When that protein binds with PD1, which is a protein, Programmed Death 1, it's just a receptor on the T cell. When those two things bind together, it's a brake on the immune system. So it stops the T cell being able to kill the tumour cell. And so what checkpoint inhibitors are just antibodies that either sit over the top of PD1, sit over the top of PDL1, lose that brake, and therefore allow the T cell to kill the tumour cell. So it's no more complicated than that. People like me stand up and make it sound complicated, but it's really relatively straightforward. It's a brake on the immune system because of two proteins. We remove the brake by binding an antibody over the top of PD1 or PDL1, allows the T cell to kill the tumour cell. That's how checkpoint inhibitors work. And people like me get really excited talking about it. So I treat melanoma, I treat kidney cancer, and I lead on acute oncology. And so in melanoma, this is the landmark trial. The 5-year data was published relatively recently, so back in September, October 2019. And so this was a trial, a 3-way trial of about 1,000 patients looking at immunotherapy, so a combination of immunotherapy versus 2 single agents. And why people like me get so excited is in stage 4 disease, patients who've got lung mets and liver mets and disease that, intuitively you think means that someone is going to die within a few months. And indeed, 10 years ago, the survival curve for melanoma looked pretty much like that. We've now got more than 50% of these patients alive at 5 years. So, just think about that for a second. I'm talking about metastatic stage 4 cancer patients and more than half of them being alive at 5 years. And hopefully you can appreciate that this line from about 3 years looks pretty straight. And so the hope is, and we know from some of the phase 1 data this is likely to be the case, that some of these patients will be long-term survivors. So again, we're talking about if you roll a dice as a melanoma patient and you get a 4, 5 or 6, you can be potentially cured of your cancer. Pretty much a 50-50 chance, and so that's pretty exciting stuff. And it was just in melanoma, but now we're using it across lots of different tumour sites. So we're using it in lung cancer, and it's a first or a second line treatment in lung cancer with or without chemotherapy in combination. So a whole different set of side effects. Again, relatively recently, it's been licensed as a first-line treatment in head and neck cancer. It can be used as a first or second-line treatment in bladder cancer, depending on the amount of PD-L1 you've got on your surface, which we may come back to. It's used as a first-line treatment in Merkel cell, which is a rare type of skin cancer I treat. We use it in Hodgkin's lymphoma. There's some bowel cancer, and really excitingly, I think, in breast cancer, there's some good data coming through now in triple-negative breast cancer, a notoriously difficult tumour to treat with or without chemotherapy. So again, being used pretty much now across the board. But this is the bit that keeps me up at night. This is the bit that we need to know about. This is the bit that we need to all upskill on. And in essence, the side effects we tend to see are autoimmune side effects that can affect any organ of the body. So this is kind of an overview of the sort of side effects we tend to see. So you can get a rash, and that rash can be a simple maculopapular rash, fairly easy to manage with antihistamines and topical creams. But as I'll talk about in a later slide, there's some more severe rashes that can be life-threatening. Colitis occurs in about 10 to 15% of patients on combination immunotherapy. Colitis often presents with new onset diarrhea, abdominal pain, bloody diarrhea. And again, it's important not to just count the number of stools, but actually to get a history about what their normal bowel habit is like and what other associated symptoms they've got. Hepatitis can be really tricky to manage. These patients are often very well, but their liver function tests will go off into the thousands, and again we need to treat them in exactly the same way. Endocrinopathies are something oncologists have never really thought about and oncology teams have never really thought about, and we see a whole host of endocrinopathies. So the most common thing I see in clinical practice is hypothyroidism, occurs in about 10% of patients. But classically, before they become hypothyroid, they become hyperthyroid. So that the thought process is that the thyroid gland gets inflamed, it gets irritated, it gets angry, and it starts throwing out all its thyroid hormones. So you get this kind of hyperthyroid picture. And that will all burn itself out, and the patient will become permanently hypothyroid. How do we manage hyperthyroidism? Typically, we just treat their symptoms. So if they're anxious, a little bit of propranolol could be quite useful if they've got diarrhea and those kind of symptoms. But most patients will burn itself out over a few weeks, 2 to 4 weeks on average, and then you treat their hypothyroidism with levothyroxine. Other endocrinopathies I see, so I'm really mindful when I see patients in clinic of highlighting the risk of diabetes. So less than 1% of patients may develop insulin-dependent diabetes. But as these indications increase all the time, so now using these in the adjuvant setting, where patients are potentially cured of their cancer, and we're using this treatment as an add-on, as a mop-up, developing insulin-dependent diabetes is a game changer. Other things that you can develop in terms of endocrinopathies are things like hypophysitis. So hypophysitis is a slightly fancy word for inflammation of the pituitary gland. Some of you may know that the pituitary gland sits in the pituitary fossa, which is in the middle part of the brain, and alongside it runs the optic chiasm, so the optic nerves, cranial nerve number 2. And so if you get inflammation of the pituitary, so hypophysitis, that classically will present with headaches, and visual disturbance. You can get pneumonitis, so inflammation of the lungs, and again, slightly more predisposed in lung cancer patients. And as you might imagine, if they can develop pneumonitis, if someone comes in short of breath with lung cancer, is it pneumonia? Is it PE? Is it pneumonitis? Is it progressive disease? It's a wide differential. But in essence, what I say to patients is if you have an organ of the body, it can become inflamed, so name an organ, put itis on the end of it, and we've probably seen that side effect. I think this is often quite useful. The details aren't so important, but it's just to get an idea when we see these side effects. So skin you tend to see early, so often after the first cycle. The GI, hepatic and pulmonary tend to occur between cycles 2 and 3. The endocrinopathies tend to occur slightly later. But this is with single agents, so this is with nivolumab or pembrolizumab. The important thing to know is if you're on combination therapy with 2 agents, in essence all of these dots will move to the side. So all of the side effects tend to occur earlier, and if you get one side effect, you're more likely to get others. So one of my young female patients recently developed an Addisonian crisis. She then developed a hypophysitis, she developed aseptic meningitis picture, hepatitis and colitis, and that all occurred within the first couple of cycles. So if you get one, you need to keep your ears out and eyes out for seeing more. Just to cover a couple of the, slightly rarer side effects. So skin toxicities, I've talked about the simple macular papular rash. So vitiligo, ironically, is something I really like to see in patients. So vitiligo, many of you will know, is a loss of the pigment in the skin. But there's good data now that if you develop vitiligo, you do better from immunotherapy than patients who don't develop vitiligo. Probably, a marker of the fact that you've had an immune response. And so if you've had an immune response in your skin, you're likely to be getting an immune response elsewhere. Bullous pemphigoid, so classically presents as I see in this picture here. So bullous pemphigoid is where you get a separation of the dermis and epidermis, the 2 outer layers of the skin, and you form these blister-like conditions. So unfortunately, we had a patient who developed bullous pemphigoid. Unfortunately, they had melanoma, had brain mets, responded beautifully, all their brain mets had disappeared. They developed bullous pemphigoid and died from sepsis when the bullous pemphigoid had ruptured. So again, that's someone who did really well from their immunotherapy, but died from a toxicity. There's some other things. So toxic epidermal necrolysis is a kind of widespread skin condition characterized classically by mucosal involvement. So often there's little ulcerations around the mouth. This is quite useful, I think, for clinic. It's called the rule of 9s. And so in essence, when we grade toxicities, when we talk about grade 3 rashes, we talk about more than 30% of the body being involved. And so using this, this very simple rule of 9s helps me work out how much of the body's involved. So, the front of one leg is 9% of your body. So if it's the whole leg, front and back, that's about 18% of your surface area. So this is quite a useful thing to use when I'm trying to grade toxicities. For smaller rashes, what about if it's just a small rash on the chest? Well, using the palm of your hand is about 1% of the body surface area. So again, that's quite useful for estimating smaller rashes. So, just a practical approach really more than anything else. These are the ones that really start to worry me. So neurological toxicities, we used to think were really rare. I think they're less rare than we believe. Partly I don't think we've been all reporting them when we see them, when there's a bit of diagnostic uncertainty. As some of you will know, we've had a couple of myasthenia gravis recently. So myasthenia gravis is a condition where you've got a nerve and you've got a muscle, and between it you've got what we call a synapse or a gap junction. And so it's acetylcholine that moves from the nerve to the muscle to tell the muscle what to do. And in myasthenia gravis, you get an autoimmune response to the postsynaptic acetylcholine receptors, so to the receptors on the muscle that's trying to listen to the nerve. And so myasthenia gravis classically presents as very much like my last patient did, with this kind of drooping of the eyes because the muscles are becoming fatigable. Often they get some difficulty with swallowing, often they get some tiredness of their general muscles, and about 10 or 15% develop respiratory compromise. And so our most recent one ended up on ITU, ended up intubated for I think 8 days, but is now recovering really well, having been treated with high-dose steroids and pyridostigmine, which is a treatment for myasthenia gravis. Guillain-Barré syndrome is a syndrome characterized by an ascending weakness. It's an autoimmune response that you get to your nerves. So classically, outside of the immunotherapy arena, it presents after a viral illness or a gastroenteritis. About 2 or 3 weeks later, patients can develop an ascending weakness. But again, with immunotherapy, it presents at any point after immunotherapy, presents in the same way with an ascending weakness. And again, we manage that with steroids, but we can also manage it with plasma exchange and immunoglobulins, which are your normal treatments for Guillain-Barré. And then there's these other rarer side effects, but we see them. So mononeuropathies can affect any nerves. So if it affects the abducens nerve, some of you will know that's cranial nerve 6, which allows you to do lateral gaze. Often these patients will present with double vision or unable to abduct their eyes, so move their eye to the side. You can develop a limbic encephalitis. Limbic encephalitis is a fancy term for encephalitis, meaning inflammation of the brain, limbic meaning autoimmune. So again, this is what it says on the tin. Patients present with confusion. They can present with seizures, disorientation. And then PRES syndrome stands for posterior reversible encephalopathy syndrome. Without getting into the details, often this presents with hypertension and this kind of classic fluid on an MRI scan. Again, rare things, but I've got no doubt that we're going to be seeing more of them. And I put this slide in partly for my own naivety. So we've had a couple of cases of patients presenting with cardiac toxicities, which we have diagnosed late, because it's often not what you're thinking about. So if someone presents short of breath and you do a CT scan and the CT scan doesn't show an obvious pneumonitis or pneumonia or a cause for it, I now go on and do an echo to look at these patients and an ECG, because we know that they can develop things like myocarditis and pericarditis. And again, unfortunately, we've had 1 or 2 of these patients who were diagnosed relatively late and died from heart failure. So again, it's about thinking about this as an early diagnosis and thinking very early about doing ECGs and echoes. So this is based around a couple of patients that we've seen. So this was a relatively early patient with metastatic melanoma on combination immunotherapy, developed some pins and needles in the feet, went into urinary retention and felt a little bit lightheaded, so a little bit of a postural drop. So any oncologist with this kind of story starts to think about core compression, because that's the way I'm wired. But also you think about the endocrine things, so thyroid and cortisol, but they were all normal. And over the next few days, the numbness increased. It started to move up the body. Referred him to neurology, did some neurological tests, and this patient had Guillain-Barré syndrome. So a really classic presentation, looking back with hindsight, of this presenting with pins and needles, some ascending weakness. Treated with steroid, treated with immunoglobulin, made a full recovery, is still in a complete remission. So other take-home message is, had a nasty side effect, yes, but actually now doing really well. And that's often a story that we see. So this is probably the bit that most of you are keen to know about, and importantly so, is how do we manage these side effects? And in essence, my simple guide to this is, if you're worried about a patient on immunotherapy who presents with a side effect, 1 milligram per kilogram of methylprednisolone is a good standard dose that no one will criticize you for. Sometimes we'll give just oral steroids. Sometimes I'll give 2 milligrams per kilogram. Occasionally I'll give 500 milligrams of methylprednisolone for certain toxicities. But I don't think that's important knowledge. I think that's the kind of cherry on top of the cake kind of knowledge. The most important thing is that toxicities, manage them with steroids. 1 milligram per kilogram is a fairly standard dose. And other things we've got available. So we've got an acute oncology app. It's free to download. Again, it's quite useful for immunotherapy guidelines, but also just for acute oncology guidelines in general. And then we've got an immunotherapy alert card. which, we know that patients don't always carry these things, but actually they often carry immunotherapy alert cards because they know how important it is to recognise these side effects early. And the observant ones of you will notice that there's a QR code at the bottom of the immunotherapy alert card that if you scan will bring up the guidelines. So again, that's quite useful. And again, I would say this, as acute oncology, I think is really important, but actually there's often acute oncology teams in your local health boards who are a really good source of advice for management. There's a couple of other guidelines out there. So, the UCONS guidelines are a one-page summary of each of the immunotherapy toxicities, and for a more complicated, sort of more complex guideline, the European Society of Medical Oncology can be very useful too. So just thought I'd add this slide in because it's difficult while you're watching this to ask questions that might be going through your head. So these are the questions I get asked most often at the end of a talk. So how do we give these drugs? We give them in cycles, anywhere between about 2 weekly and 6 weekly. They're given via a drip, and we don't dose reduce them. So it's not like chemo. You can't go down to a 70 or 80% dose. You're either given the immunotherapy or you're not. Which again is important to know, because again, when we started giving immunotherapy, I'd have people ringing me and saying, they're just not as well as they were, do you want to dose reduce? Well, you can't. You either have an immune response or you don't. What about older patients? So with the chemotherapy, we often think, well, they're probably not fit enough, chronological age or physiological age. We know physiological age is what we should be doing. But actually we know that older patients do at least as well on immunotherapy as younger patients, but actually it seems that if you're over 62, you seem to have a better response to immunotherapy. We don't know why, but it does seem to be the case across lots of different trials. There's a lot of work going on with the microbiome at the moment and the effect of antibiotics. Again, keeping it simple, I say to avoid antibiotics within 6 weeks of starting treatment, but if you need antibiotics whilst you're on the treatment, go ahead and do that. Excuse me. What about if you get one of these nasty side effects, one of these, myasthenia gravis or one of the grade 3-4 toxicities? We don't normally re-challenge these patients with immunotherapy. That said, if you're going to die from your cancer and we've got no other options, it's a conversation that we have between ourselves and the patient. This is really important that patients know this. So what about steroids? So steroids dampen the immune response. We use it if you develop a side effect. Is it a problem? Will it stop you responding to your immunotherapy? The data we've got at the moment suggests that you should not be on steroids ideally before you start treatment, but using steroids when someone gets a nasty side effect doesn't seem to affect the efficacy. And then finally, people often say to me, well, what about patients with autoimmune conditions? What about Crohn's disease? What about rheumatoid arthritis? Increasingly, we are treating these patients, but again, it comes with the clear discussion with the patient that it may flare everything back up and we may need to get your specialist involved early to manage it. And regarding fertility, we still just don't know if it affects fertility or not. But with patients now living 5 years or longer, it's important that we consider these issues. Okay, so just in a couple of final minutes, let's just look at some questions which I'll let you have a think about. So for those who, if it may be difficult to read the slide, so this is a relatively young patient with melanoma on immunotherapy, develops diarrhea, importantly with the associated abdominal pain. So this isn't just diarrhea. Opening bowel 8 times a day, normally opens them once every couple of days. So that's important because that means that it's more than 7 times that, what's normal for them. No PR bleeding, and how are we going to manage this patient? And so hopefully while you're watching this, many of you are shouting methylprednisolone 1 milligram per kilogram, because that's what I would be recommending that we did with this patient. Often in reality, these patients will be managed with a bit of loperamide and a bit of octreotide if it's not settling, some IV fluids. But that's not the way to manage immunotherapy patients. This patient needs to be on steroids. This is likely to be an autoimmune colitis and needs to be managed aggressively and quickly. So this is a second patient, again on immunotherapy for melanoma. Again, similar story, develops this kind of bloody diarrhea. You started them on the steroid, which is great, but unfortunately now it's not responding despite 3 days of steroid. And so this is the sort of patient I'm thinking about giving infliximab to. So infliximab is something called an anti-TNF alpha drug. It basically works by really dampening down the immune response. TNF alpha is, I guess, one of those kind of interleukin, cytokine kind of molecules which stimulates the immune response. And so infliximab is very good at treating diarrhea that's not responding to steroids. And often these patients will respond within a day or so once you give them the infliximab. It's often important that we do things like scopes to check there's no other cause for the colitis. But in essence, the take-home message is if someone's not responding after 3 days of steroids, you need to be thinking about other immunosuppressive agents, of which infliximab is one of them. And then finally, so this is a slightly trickier question, I think. So this is a bladder cancer on second-line immunotherapy, presents short of breath with a little bit of pain in the chest, a little bit of pain on deep inspiration. Done pretty well up till then. What's the most likely diagnosis? And in essence, I think this question highlights the fact that this could be any of these diagnoses. So this could easily be pneumonitis, it could be a pneumonia, it could be progressive disease. Actually, this in particular patient was a pulmonary embolus, so pain on deep inspiration, fairly classical history. Excuse me, but the point is that these side effects can occur, in the lung. It could be any of these kind of toxicities that have developed, and it's really important that we take a wide approach to our differential diagnosis. So I guess that's pretty much it from me. So other than to say that I think immunotherapy is exciting, it's now being used across lots of different tumour sites. There are these autoimmune side effects. They are manageable as a rule. Most of them are reversible. The endocrinopathies aren't, and they often need to be on permanent treatment for those. We use steroids a lot. It's important we taper them relatively slowly, otherwise patients will flare back up. There are roles for other immunosuppressive agents, such as infliximab for bowel. We haven't covered it, but you can use things like mycophenolate for liver toxicity. And it's important to know it's now difficult to estimate a prognosis for these patients. If you've got melanoma and you respond, you might be cured. If you don't respond, you may die very quickly. And so that makes it tricky, but also really exciting. And I'm very happy to answer any questions.